Okay, let's dive in. We've got a really interesting source today. It's a specific post-op protocol put together by vascular surgeon Dr. Gregory Weir.
Right.
And this is focused on patients recovering from surgery involving the femoral artery.
Yeah, things like fem bypass, iliofemoral bypass, also thrombectomies and darterectomies in that area, pretty major stuff.
Exactly. So our plan here is to, cut through the details in these notes and really pull out the essential steps for recovery.
And what strikes me immediately is just how precise it all is. It
Yeah.
really highlights how delicate this kind of vascular work is. Every step feels geared towards protecting that surgical site.
Totally. And the first thing the source hits us with is blood pressure, specifically mean arterial pressure, the MAP.
Oh, yeah, the MEP.
It gives this really tight range. Keep it strictly between 70 and 100 millimil rate Chambeau way. Why so specific?
Well, that window, 70 to 100, it's absolutely key. You're trying to minimize stress on that fresh arterial repair. If the MAP creeps up over 100, well, it's too much pressure on the sutures.
Right, you risk bleeding or messing up the graft.
Exactly. And the protocol actually says use nitrosine, a vasodilator, to gently nudge it down.
Okay, brings it down gently.
But then conversely, if the MAP drops below 70, you risk poor perfusion, not enough blood flow getting downstream to the tissues.
Okay, so too high is bad, too low is bad.
Ah.
Got it. And the protocol gets, well, a bit more detailed if the pressure is low, right? It brings in CVP, central venous pressure.
It does, yeah.
Why look at CVP when the MAP is low? What's the connection?
It's basically trying to figure out why the pressure is low. CVP gives you a sense of the patient's fluid status.
Ah, okay. Like how much fluid is in the tank.
Pretty much. So if MAP is low and CVP is low, say below 10 centimeter H2O, it points towards the patient being volume depleted.
They need fluids.
Right. So the protocol says give a Ringer's bolus, fill the tank.
Makes sense.
But if MAP is low and CVP is high, over 10, they probably have enough fluid volume. The issue is more likely their vessels aren't tight enough, not enough tone.
So giving more fluid wouldn't help, might even overload them.
Precisely. So that's when you'd use noradrenaline, a vasoconstrictor, to help squeeze those vessels a bit, raise the pressure without adding more fluid.
Wow, that's smart. It's like a diagnostic stack built right into the treatment plan.
It really is. Addresses the likely...
Yeah, treating the root cause, not just the symptom. The source also mentions the standard things, oxygen, elevating the limb.
Right, standard supportive care. But that detailed MAP and CVP interplay, that's definitely a core piece of this protocol's logic.
Okay, then it shifts to labs, monitoring what's going on inside.
Yes, specific checks.
Day 0 checks are HECT and TROPT. Then day 1 adds UKE, FBC, CRP, myoglobin, and TROPT again. And a clear target for HTT. Keep it above 30%.
And each of those tells a specific story post-op. HUT hematocrit, that's red blood cells. Keeping it above 30% is partly about oxygen capacity.
Right.
But mainly it's watching for bleeding. A sudden drop on day 0, that's a red flag for the surgical site.
Okay, early warning. What about the others? UKE.
Urea, potassium, electrolytes, kidney function, fluid balance ties back to that CVP stuff.
Got it. FBC.
Full blood count, general status. CRP flags inflammation. Myoglobin can indicate muscle injury, maybe from poor blood flow before surgery.
And TROPT again on day 1. Cardiac marker.
Yeah, Troponin T vascular surgery like this can stress the heart, so these labs give a pretty comprehensive picture.
Okay, now for something that really stood out to me, activity. Source is, well, incredibly strict. It says the patient may not sit upright at all.
Yes, unequivocal.
And day 0 is strict bed rest. That means 0 bending at the hip.
Absolutely. And this is probably the most critical restriction. Think about where that femoral artery repair is, right in the hip crease. Sitting up puts direct tension and a sharp angle right on that spot.
Oh, wow. I didn't picture it quite like that. So it could stress the sutures, kink the graft.
Or cause bleeding. Yeah. So strict bed rest initially and absolute no sitting is non-negotiable to prevent purely mechanical strain on that healing artery.
So even when they start mobilizing, maybe day 1, it has to be super careful to avoid that sitting position.
Exactly. Gradual controlled movement, yes. But avoiding hip flexion is key. It's interesting, though.
Yeah.
The protocol does allow them to eat and drink on day 0.
Oh, right.
So it tells you the restriction is laser focused on the mechanics of the surgical site and the hemodynamics, not just a general keep the patient still order.
Yes, it really highlights how vulnerable that specific anatomical spot is after surgery.
Definitely.
Okay, so pulling it all together, this protocol from Dr. Weir, it's really defined by these intensely specific targets, blood pressure, flow.
Guided by CVP when needed.
Right. And a clear lab schedule watching for bleeding, inflammation, organ stress, and these incredibly strict rules about positioning, protecting the repair site above all else.
Yeah, it really paints a picture of just how critical that immediate post-op period is for these femoral artery procedures. The risks, rebleeding, graft failure, they're significant.
So we've sort of distilled the essence here. Tight MAPCVP control, targeted labs, and that absolute ban on hip flexion initially.
It's a textbook example, really, of protocol design managing very specific physiological risks.
Definitely. So here's something to think about as we wrap up. Given how incredibly specific this all is, the exact numbers for MAP, the HCT level, the zero tolerance for sitting, what does that level of detail suggest about how easily things could go wrong after these surgeries and just how finely tuned our interventions need to be?